Hello and welcome to the basics of endotracheal intubation. By the end of this session, you should be able to describe the indications for endotracheal intubation, outline the pre-procedure steps to be taken, list the pharmacological agents used in the process of endotracheal intubation, describe the laryngoscope insertion technique, explain the steps taken to verify the placement of the tube, discuss the post-procedure steps, and finally explain the complications of this procedure. So, endotracheal intubation is indicated to assist ventilation during a surgery or when a patient cannot protect their airway in the situation where their Glasgow Coma scale is less than 8. This deems them high risk for aspiration. In patients who may have potential airway obstructions such as airway burns, epiglottitis, or neck hematoma, or in patients who have inadequate ventilation or oxygenation, as in cases of acute exacerbation of COPD, bronchial asthma, or ARDS. Let's look at the pre-procedure preparation. So they are equipment preparation, pre-oxygenation, and pre-medication as well as paralysis. As for preparation of equipment, ensure that all the equipment are arranged in a trolley for easy access. These include laryngoscope handles and the blade, the endotracheal tube with its stylet, oropharyngeal airway, suction and the suction catheter, lubricant, a 10 cc syringe for balloon inflation, nasogastric tube, cardiac monitor, saturation monitor, a bag valve mask, and of course, medications. For pre-oxygenation, ensure that the bag valve mask is positioned well. Oxygenate up to 98% or more. And for pre-medications, there are two sets of medications that need to be prepared, which is medications for the induction phase, including fentanyl and midazolam, and the paralytic phase, which includes saxametonium or rocuronium. Now, these are the induction and the paralytic agents. Let's begin with fentanyl. It comes in an ampule of 50 mics in 2 mL. This is a pre-medication that's prepared prior to intubation. The dose to be administered would be 1 to 2 mics per kilogram intravenously. Then we have rocuronium and saxametonium, which are examples of paralytic agents. For rocuronium, it comes in a form of vial of 10 milligrams per ml. It is used for muscle relaxant before intubation, and the dose administered would be 0.6 to 1.2 milligrams per kilogram intravenously. Lastly, saxametonium. It comes in the form of an ampule. So 1 ampule equals to 100 milligrams per 2 mL. The indication would be for muscle relaxant. And the contraindication here would be renal impairment or hyperkalemia. Dosage that should be given would be 1 to 1.5 milligrams per kilograms intravenously. Let's look at reversal agents because these are important in the event there is too much of administration of or toxicity. Naloxone is given for reversal of opioid depression. 1 ampule equals to 0.4 milligrams per ml. The dosage that can be administered would be 0.4 to 2 milligrams intravenous, intramuscular, or subcutaneously. You can repeat this 2 to 3 minutes if needed and not to exceed 10 milligrams. As for flumazenil, it is used for the reversal of benzodiazepine overdose. 1 ampule equals to 0.1 milligrams per ml. The dosage to be administered would be 0.2 milligrams intravenously over 15 to 30 seconds, and if there's no response after 30 seconds, administer gradually a higher dose as you up-titrate. Maximum cumulative dose should be 3 milligrams per hour. Now let's take a look at what has to be done pre-procedure. First, explain to the patient the risks and the benefits of intubation if the procedure is elective. Otherwise, in an emergency situation, you may want to call the family members and the next of kin to explain and inform the procedure. Video calls, if time permits, if unable to meet the family members on time. Ensure that you wear your PPE prior to the intubation process, and ensure that the patient has 2 large bore intravenous cannula inserted for medication and fluid administration. Now let's take a look at the insertion technique. So before you insert your laryngoscope, ensure that the induction agents are given as per requirement. Pre-oxygenate the patient with high concentration of oxygen using the bag valve mask device for 3 to 5 minutes. Position the patient with their neck flexed to 15 degrees and head extended on the neck with no lateral deviation. Stand behind the head of the patient and open the patient's mouth and inspect. Remove any dentures or debris and suction any secretion. By holding the laryngoscope in the left hand, insert it looking down its length. Apply traction to the long axis of the laryngoscope handle. This lifts the epiglottis so that the V-shaped glottis can be seen. Pass the laryngoscope down the tongue, slide it down the right side of the mouth until the tonsils are seen, and move it to the left to push the tongue centrally until the uvula is seen. Advance over the base of the tongue until the epiglottis can be visioned. Next, lubricate the end of the endotracheal tube and insert it in the groove of the laryngoscope so that the cuff passes through the vocal cords. Remove the stylet in the endotracheal tube and the laryngoscope and inflate the cuff of the tube with 10 mL of air using a syringe. Attach the endotracheal tube to the ventilator circuit and ventilate with high concentration oxygen. Observe for chest expansion and auscultate to confirm positioning. Secure the endotracheal tube in place with a twill tape ribbon. If it takes more than 30 seconds for this process, remove all equipment and ventilate the patient with a bag valve mask device until ready to retry intubation. Next, let's look at the placement of the tube check. So you may do this by visualizing the tube passing between the cords, auscultating the lung sounds bilaterally with ventilation, noticing the fog in the tube with exhalation. Patient's oxygenation has improved or maintained in the mid-upper 90s, and you can confirm the placement by doing a portable chest X-ray. Next, post-procedurally, obtain vital signs, ensure that the patient is given adequate analgesia and sedation, insert a nasogastric tube and urinary catheter, arrange for a chest X-ray to confirm the placement of the endotracheal tube, and finally, arrange for a CT brain if indicated. There are both short-term and long-term risks and complications associated with endotracheal tube placement. As for short-term complications, these may include esophageal placement of the tube, which is one of the most serious complications and is improper placement of the endotracheal tube into the esophagus. If this goes unnoticed, the lack of oxygen to the body could result in brain damage, cardiac arrest, and death. Temporary hoarseness when the tube is removed, pneumothorax, aspiration of contents of the mouth or stomach during placement, and atelectasis. Long-term complications may persist or arise later, and these can include tracheal stenosis or narrowing of the trachea, tracheomalacia, spinal cord injuries, tracheoesophageal fistula, and vocal cord paralysis, which is a rare complication that can cause permanent hoarseness. So let's recap. Endotracheal intubation is a method used to ensure a patient's airway is kept open and secured to enable mechanical ventilation. Ensure preparation of equipment, medications, and patient before the procedure is done. Induction agents are carefully prepared according to the recommended dose per body weight to ensure a smooth induction which enables the intubation process. Take note of the technique of laryngoscope insertion, which begins with ensuring patient's head is tilted 45 degrees to the back while it is hyperextended to ensure airway is parallel to the mouth opening. And as soon as the tube is inserted, take the necessary steps to verify tube placement and proceed with post-procedure care. Well, we have come to the end of this topic. Please find and click the link to open Advanced Cardiac Life Support Guidelines for further reference in the section below. Thank you.